Hello, my name is Arthur Brewer. I'm the medical director for Rutgers University Correctional Health Care. I'm going to spend the next 20 to 35 minutes talking to you about primary care in a correctional setting. I have no actual or potential conflicts of interest in relationship to this presentation. Um, in the next few minutes, I want to talk to you and share with you about information that I think that really have been very instrumental in being able to help institutions provide care, and specifically primary care medicine within correctional institutions. The first institution, or one organization I'll talk to you about, is the National Commission on Correctional Health Care. And also I'll talk to you about the American Correctional Association. I think each of these institutions, with the development of their standards and in healthcare, I think have been very helpful in prisons and jails in being able to provide primary care medicine to their incarcerated individuals. I'm also going to talk to you about the similarities and differences between jails and prisons. I think that's important to understand, particularly in the sense that understanding the difference between the two facilities, also consequently you'll be able to understand how primary care may be somewhat similar or in some aspects somewhat different. I'm also going to talk to you about a particular model of care that I think is somewhat innovative and different than care that's provided in other organizations throughout the country. And also, I'll close by talking about what I believe are some of the benefits and some of the challenges of providing primary care in a correctional setting. I'm going to start with just sort of acquainting you with the American Correctional Association. It is apparently one of the oldest correctional organizations that's dating back to the late 1800s. Was known as the National Prison Association. This organization is involved in the development of providing direction to the entire prison or jail. And in 1989, it provided some specific standards around delivering health care. In 2001, they updated their performance standards around correctional health care. And this organization, as I mentioned earlier, I think along with the National Commission, I think have been very helpful in sort of creating some minimum basic standards that I think allow for people providing care to provide fairly decent primary care to their incarcerated individuals. The National Commission is a bit younger than the American Correctional Association. It came out of the American Medical Association study of jails which were found to be inadequate, disorganized, and also there was a lack of national standards. In collaboration with other organizations, the AMA established a program that in 1983 became the National Commission on Correctional Health Care. This organization set standards for health services in correctional facilities. This organization, unlike the ACA, is specifically devoted to healthcare. The ACA has developed standards for all aspects of jails and prisons, as well as healthcare, but the National Commission is focused primarily on healthcare. Now, with this involvement from health and legal and correction professionals, they've provided standards that can be used applicable for jails, prisons, as well as juvenile confinement facilities. Now, again, I'm going to spend a little bit of time talking about jails And in the next slide, we'll talk about prisons. Jails are a place where people are arrested and may await their trial. Or also, it's a place where some people may spend their time if they're convicted of a misdemeanor. Um, Generally, those crimes involve a sentence of less than a year, which means that in many places these individuals would spend their time in a jail. But in most cases, you'll see that jails are very high turnover. And in fact, data from 2014 indicated that the average jail throughout the United States turned over, roughly about 60% of its population within the course of the week. And the range of this turnover could be as low as, just below 50% to above 100%. So the issue with jails is there's a rapid turnover of patients, and you can imagine as a consequence of what things you're able to do, that we'll talk a little bit more about that. The smaller the facility, the higher the turnover rate. And one thing to note, that jails are run by states primarily, but of special note, there are federal prisons, and the difference between those are people who are convicted of state crime as opposed to federal crimes. And as mentioned, that people who go to prisons, generally they're spending a sentence or time, or they've been sentenced to a time of more than 1 year. Back in 2008, the average length of stay for an individual was just a little over 2 years. And of course, the range of stay back in 2008 was a little bit over a year to up to 43 months. So that's the range. And again, the type of offenses that people are convicted of are public order offenses, drug, property, and violent crimes. Again, the special note about prisons is that there's a longer stay than jails. Now, the next few things I'm going to sort of run through are essentially things that have been established by the standards, both from the American Correctional Association and the National Commission on Correctional Health Care. And I think these standards have helped shape and support the ability for organizations to provide primary care medicine to is when an individual arrives and it's newly admitted to a jail or a prison. And to be sure that there's not any emergent health care needs that need to be addressed, such as the person needing to go into the emergency room or perhaps being hospitalized. And again, you have a variety of settings where people are literally picked up off of the street and brought to a jail. And so, people could be acutely intoxicated, they could be injured, they could be experiencing some acute medical problems. So it really is important that there's a clearance that's done very quickly to sort out whether the person is in need of some acute medical or mental health care, for that matter. In terms of, after the clearance is done and established that the patient is somewhat stable and can come into the facility, that for the National Commission, the expectation is that person should have a complete history of physical within 7 days. And for the American Correctional Association, the expectation you have a little bit longer, that could happen within 14 days. In both organizations, the expectation is that a mental health screening is done within 14 days, and also a dental screening and evaluation is done with 7 days. So clearly, whether a person is admitted to a jail or prison that's accredited by the American Correctional Association or National Commission on Correctional Health Care, this first slide demonstrates what the expectations are. People are involved in dental needs. Now, again, with the American Correctional Association and National Commission on Correctional Health Care, whether it's a jail or prison, and they should be able to access it 7 days a week. And it can be written or oral, and also it's really important to document these requests. And however these requests come in, they must be triaged by a qualified healthcare professional so that a decision can be made, oh, we need to bring this person down quickly to assess their complaint, or they can be scheduled within 2 to 3 days to be seen by places that are accredited by the ACA or NCCHC. Inmates have access to emergency services should be provided. The previous slide touched on about inmate requests, which would imply that they're not necessarily emergent services, but in addition to being able to provide non-emergent services, the facility should also be able to provide emergency services, which means then they should have access 24/7, whether it's medical, dental, or mental health needs. Obviously, the facility should be able to transport the patient from the facility to a designated hospital if that's required. And clearly, you're going to need the type of providers involved to be able to make that decision. So physicians should be on call, dentists should be on call, and mental health staff should be on call to interact with the providers at the site to sort of help them sort out what needs to be done or done for the patient. Clearly, you're going to need some security procedures for immediate transfer of the patient, and clearly you're going to need medical, drugs or medical equipment to be able to provide the necessary services that can happen or be needed. In addition, both organizations, whether jail or prison, should have protocols that where nursing staff are able to assess the patient and provide pharmacies or drugstores where you and I can go and purchase aspirin or Motrin or any other sort of medications that we can address, whether we have a headache or a sprained ankle or an upper respiratory infection, or any variety of things that that people can go and self-medicate themselves by going to these facilities and purchasing these. So all of these institutions have what's called nursing protocols, which allow the nurses within normal vital signs and with very prescribed symptoms, they can administer over-the-counter medication. Prescription medications are not provided in these protocols, only in exceptions would allow the person to give prescription. The National Commission and the American Correctional Association really expect for to occur is that there should be clinician orders, should be evidence-based and implemented in a timely manner, discussed with patients, and also that there's just a provision of health care so that if tests are ordered, they should be reviewed by a clinical person. Treatment plans should be established. The patients are seen by qualified healthcare professionals if they've gone out to emergency room or if they've returned from the hospital, and also if people are being released from a facility that's incarcerated. Another sort of important element in primary care is obviously when people are released that discharge planning is provided so that people with serious health issues can have their care transition from the jail or prison to a necessary part, which also includes you may need medications. The patient should be provided an appropriate amount of medication, certainly to get them to their next appointments in the community where that they can continue and prescribe additional medications. Centers so that you can transfer the care to those individual patients. And it's also important to have discussion with your inmates about aftercare. And again, it's important to have specific appointments and medications for the patients upon their discharge from the facility. And also, it's imperative that there's a timely exchange of health information. Um, Clearly, in addition, while the individual is spending their time in a jail or prison, if they have a particular medicine that still are available and are ordered by a health important that the healthcare provider also is able to be able to prescribe those medications. In addition, the expectation is that while people are spending time in prison, that people be providing information on their chronic illness or just self-care, and use this as an opportunity to educate people about sort of important healthcare needs. One critical piece, and I think this is sort of one of the mainstays of primary care, is really the management of chronic illnesses. And as I mentioned, upon admission to the facilities, a fairly good history and physical should be attained, whereby people who have chronic illnesses can be identified. And the expectation is that they'll be enrolled in what's called the chronic care clinic, and the expectation is that you use national clinical practice guidelines to sort of standardize the management of these patients with these particular diseases. The more common chronic diseases that exist in the community obviously exist in the incarcerated population, asthma, diabetes, hypertension, HIV disease, seizure disorder, tuberculosis, sickle cell disease, and also any of the major mental illness, depression, bipolar disorder, and psychosis. So it is important that these diseases are identified and that people are enrolled in a clinic, and there is some very specific expectations. Now, obviously, the list of chronic illnesses is not exhausted, but also the organizations help people define and understand what a chronic illness is, and so it's an illness or conditions that affects the individual's well-being for an extended interval, usually minimally 6 months. It's not curable, but can be managed to provide optimal functioning. The chronic illness should be documented on the problem list in the medical record of the patient. Once again, it's important to use established national clinical practice guidelines in the management of the various diseases. And also with these guidelines, there's an expectation about the frequency of the visits. It's important also to establish how well the condition is controlled, and the language in using good, fair, or poor. And also it's important to establish the status, whether it's a stable, improving, or deteriorating. And the expectation, if people are deteriorating or needing improvement, that you make specific adjustments to the treatment plan, and you should have a plan about the frequency of testing and therapeutic regimens that are being recommended, such as diet or exercise, or specific, critically important in the management of the patient. And once again, if there's any reason you need to sort of deviate from a specific guideline or protocol, it's important to sort of document that reason for deviation. I want to just spend a little bit more time about chronic care. So that's sort of the cornerstone of being, establishing and providing primary. In most jails throughout the country, there is minimally almost a 50% turnover rate of the jail, and even for the larger jails, that minimally that you can have half the population turnover within a week. So you can imagine that being able to do some of this chronic care can be very challenging in the jail. Whereas in a prison, though, as I mentioned, that the stay there is much longer. Minimally, people in a prison are there from a little over a year, but often up to to 40 45 months. So in that case, in the prison, I think there's a real opportunity to sort of do and provide decent chronic care given the length of time that you have with your patients there. Um, One of the other things important that for some patients who have an illness that requires daily monitoring, that all facilities need to have a unit which is referred to as an infirmary. It should be a designated, whether it's they need to be monitored or they need a medication that's got to be administered, they need oxygen, or they need assistance with daily living. Now, this is an area where they need skilled nursing care, but the expectation is that this is not to be able to provide care to the level of a hospital. The expectation is that people in this designated room or dormitory are within sight or hearing of healthcare providers. It's critical that a registered nurse is minimally on site at least once in every 24 hours, that the patients are required for the management of patients that are placed into um, what's known as the infirmary. One clearly important part of providing primary care and in providing care to an entire person, and I think one of the really good things about being incarcerated that's treated, but the expectation is that mental health services are provided also to individuals so that they can get individual therapy, they can have group therapy, that if there's a particular crisis where the person needs some immediate intervention, people should have access to medications that can help them with their depression or whatever illness that they have. And also, they need to have the access to inpatient mental health care if that's needed. Like the outpatient medical care, the expectation that outpatient mental health care, that you need to minimally see the patient at least every 90 days, but obviously they may need to require some more frequent visits. And one important piece that's particularly uh, important, I think, in all incarcerated individuals, but I think patients who are in a jail have a higher risk of this in prison, is a suicide prevention program. Suicide occurs at a much higher rate in jails than probably many other environments and perhaps than prison. And so it's really important that there's a very good suicide prevention program in terms of being able to identify patients that are at risk for suicide and being able to get the appropriate assessments and housing of those patients to prevent them from harming themselves. Um, One other additional piece that's important, obviously, for women, particularly coming into jail. Particularly, as I mentioned, people may be literally picked up off the street, that it is important that women, the issue around contraception, whether they were using it prior to being incarcerated, and particularly the woman may have engaged in some activities that may put her at risk while she's incarcerated for an unwanted pregnancy. So it is important that people have counseling and then you're able to talk to women about this very specific issue, and that the ability to be able to continue contraception or initiate contraception is certainly important. Um, and I think that that's a sort of important piece, and as you can imagine, that's an important part of primary care medicine, particularly for women, and of being able to address women's health care issues. Intoxication and withdrawal, I think, is a huge and important issue, particularly at jail, when people are incarcerated. I think one of the other facts and the realities about people who are incarcerated, and you probably are familiar with it, that a significant proportion, probably arrested, are either under the influence of alcohol or some other drug, or clearly are struggling with substance abuse. So intoxication and withdrawal is a very common issue that jails have to deal with. Um, and so consequently detoxification and its process is an important thing that jails are able to be able to provide for patients. They need to have established protocols. It's important to have national cases as appropriate, that there's the ability to transfer the patient to a hospital. Um, at this point, the previous slides, I'll just go back to them, that I've talked about, sort of gives you the basic foundation of providing primary care, which I think exists and probably in some variation in most jails or prisons. And the thing to keep important, what I reviewed here, are the expectations that the American Correctional Association and the National Commission on Correctional Health Care expects that their accredited organizations would, the National Commission on Correctional Health Care, I think will have sort of the foundation for providing very good primary care medicine. The next place I just want to point out is a model of care that's done in Hampden County, which is a county in Massachusetts. It's a jail, as I mentioned, that jails are either managed by counties or cities, and this is a county jail. And they have a very, I think, sort of interesting, I mentioned that you need to keep in mind that most jails, half of their population, this model really sort of addresses that issue for state or zip code, and or prior of this county, so that people from a particular health zip code are matched up with a team that has a relationship with the center from the zip code in which they have come from, or based on their previous contacts. So it's a dual-based team in 4th Health Centers and the jail. There's physicians and case managers in both the community health center and the jail, and nurse practitioners, and there's a primary nurse that are primarily in the jail base. And so I think this approach, I think, sort of allows for the reality of a jail where people are in and out, so that people are, while they're incarcerated for whatever length of time, and once they return back, they can pick up that health care. So I think this is, a fairly novel, important model that I wanted to share with you. I just want to talk about availability of condoms. That this is sort of a controversial circle in hepatitis C infection. There's a high prevalence there, and obviously as other sexually transmitted, allow for or make condoms available. I believe are major concerns that they can be used as weapons, that condoms can be used to hide contraband. Jails and prisons, that somewhat different, and I think in some of these large jails, they've sort of acknowledged that and sort of taken a different approach to that problem. Also, the availability of emergency contraception, I think, is important. We talked about that. I think the NCCHC clearly has established a standard, and again, all of their facilities that are accredited, it's clearly been established that they need to have those available to women. New York City jail, aside from that, have recognized the importance of that and have made the availability of emergency contraception, as well as Washington State also mandates availability of emergency contraception for women, clearly in certain instances. I'm going to sort of wrap it up now and sort of talk to you about what I think about some of the opportunities in correctional health care. And I must admit that I think some of the opportunities are those who, for the most part, historically have not accessed health care for a variety of reasons. And so I think the fact that they're being incarcerated and they're with us for a period of time, that we can provide some important education about just general healthcare issues, um, but specifically also talk to them about communicable diseases, chronic illnesses, mental health disorder, and substance use disorder. In addition, I think there's an opportunity to provide some prevention, through education, whether it's about HIV disease, hepatitis C infection, or sexually transmitted diseases, or other health problems. I think there's an opportunity through education to assist and prevent the development of other diseases. And also, I think through the screening process where everybody comes through and they get. Um, and I've already mentioned that there are opportunities for early identification of disease, communicable diseases, chronic illnesses, mental disorders, and substance use disorders. I think, historically, jails and prisons have been an important role in identifying tuberculosis, identifying and treating people with sexually transmitted diseases, certainly identifying individuals with HIV infections, and currently also identifying people with hepatitis C infections. So historically, jails and prisons have been a really an important place where many communicable diseases were being detected, and previously patients had no idea they had these problems. And obviously chronic illnesses are identified, mental health disorders are identified, and certainly substance use individuals get access to treatment, which is terribly important. And also many providers talk about how also there's a huge amount of data that's available about these individuals that I think that's helpful in sort of population health information that I think can be helpful in terms of identification of diseases or tracking of diseases. And one other opportunity, I think it gives us an opportunity to initiate reentry programs for people. People who go to prison also return to their community. So there's an opportunity there for people who are struggling with substance abuse to engage them and direct them into medication-assisted therapy for drug treatment, enroll people into state Medicaid programs, and connect them also with other aftercare programs so they can continue their health care. And correctional health care are the sort of episodic care where people may be seen by different providers at a particular jail or prison versus a primary care model where individuals in a certain housing area will be continued to be seen by the same provider, so they get to know them. So that's one of the real challenges. I think also the burden of illness is somewhat of a challenge, as you're aware of, that HIV and hepatitis C and substance abuse disorder and the severity of illness. I think the burden and the healthcare burden is probably a lot greater in this cohort of people than people who are in the general community, which may have multiple organizations involved in the healthcare and the patient. And specifically, there may be one organization providing healthcare, another organization providing mental health care, and yet a third organization providing substance use disorder care. So, as you can imagine, the more one other thing that's worth mentioning is that for the most part, inmates in their lives in a correctional setting, they're really, you can have your meals. This is what time you may be able to communicate with your loved one or have your visits or to go out to rec. And so they're told what to do and when to do it, and if they don't do it at those specific times, they're going to have to wait till that time comes around again. Versus collaboration, and in primary care, it's all about collaboration. You're working with the patient as a primary care provider, and you're trying to understand what they need and also trying to meet them where they are and try to move them forward. So it's a very different sort of relationship than the sort of in an island of which we're trying to encourage a collaboration that is surrounded by a sea where there's command control, and that can be a bit challenging. Um, Transfers of care and reentry, again, as I mentioned, particularly with jails, realistic, or on prisons, I think, on the other hand, where people are there much longer. I hope these are my references. I hope the past few minutes have been very helpful to you. I'm excited to have been able to provide this information to you, and excited that medical students are interested in such an important aspect of healthcare, and hopefully many of you may decide to pursue this as a career. Thank you very much.